Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. Usually, when we talk about a medical diagnosis, there's this expectation of precision. Like you break your arm, the x-ray shows that jagged white line, and the clinician just points to it.
Right. It's very clean. It's visual.
Exactly. It's incredibly comforting to have a definitive category like that. But then you step into the world of primary care and mental health, and we are looking at a diagnostic landscape that is honestly just murky.
Oh, absolutely murky.
And as an advanced practice nursing student listening to this, you are stepping into a system that has literally become the triage point for the mind. I mean, you're the first responder to a massive psychological crisis.
Yeah, and that murkiness is exactly why primary care has to shoulder this burden right now. I mean, we are operating inside a system with severe psychiatric specialist shortages.
Plus all those complex insurance barriers, right?
Right, exactly. Finding a provider who takes a specific coverage can take months. And then you add in the profound, lingering psychological trauma of the COVID-19 pandemic, and, well, the primary care clinic is basically the only safety net left.
It's a huge responsibility.
It is. We are talking about a staggering financial burden here, like over $225 billion spent on mental health services in just a single recent year.
Wow. $225 billion. And, the human cost behind that number is what you actually see sitting right there in the exam room.
Yeah, the real people.
Right. Nearly 50 million American adults are experiencing a psychiatric disorder. And suicide rates are drastically high. It's the second leading cause of death for demographics ranging from early adolescence all the way up to age 34.
It's devastating.
It really is. And as the clinical literature points out, this burden is disproportionately carried by veterans, who are 1.5 times more likely to die by suicide, alongside marginalized groups, BIPOC, LGBTQ plus individuals, and those living in poverty. So navigating this without getting completely overwhelmed requires a rock-solid clinical framework for our APRN students.
You build that framework starting with validated screening tools. I mean, before you even begin a deep, subjective psychiatric interview, you need objective data, just to establish a baseline.
So we're talking about tools like the PHQ-9.
Exactly. You'll use the PHQ-9 for depression, the GAD-7 for anxiety, the Columbia-Suicide Severity Rating Scale for imminent risk, and the AUDI-ATC or CAGE questionnaires for substance use.
Which is great because those tools quantify the subjective experience so you can actually begin to map it to a clinical diagnosis.
Right, and mapping those screening results brings us straight to the DSM-5-TR.
Which has changed, right? I know earlier iterations of the DSM used an axial system, basically separating medical conditions from psychiatric ones across different axes, almost like, treating the mind and body as completely different organisms.
Yeah, and the shift to a non-axial system in the DSM-5-TR is, it's one of the most important conceptual changes for a clinician to grasp today.
Because it forces you to look at the whole picture.
Precisely. By collapsing those axes, the manual explicitly recognizes that mental and physical health are fundamentally intertwined. I mean, you cannot separate a patient's uncontrolled diabetes from their major depressive disorder. They feed directly into one another.
That makes a lot of sense.
And the manual details the specific symptom type, number, intensity, and duration required for a diagnosis, which, practically speaking, maps directly to the ICD-10-CM codes you need for billing and reimbursement.
Okay, but I have to push back a little on the rigidity of those criteria. Like, what happens in the clinical gray areas?
What do you mean?
Well, if a patient is sitting across from you, clearly suffering, but they only exhibit, say, 4 out of the required 5 symptoms, or maybe they haven't quite hit that 6-month timeline for a formal DSM diagnosis, do we just label them subclinical and send them away?
Oh, no, absolutely not. That is a critical tension in primary care. Subclinical absolutely does not mean treatment is unnecessary.
Okay, good.
Atypical or subclinical presentations can still cause massive subjective distress. The ultimate threshold for clinical attention isn't just a symptom count, it's functional impairment.
So asking things like, is this affecting their ability to hold down a job?
Exactly. Are their personal relationships deteriorating? Can they perform basic activities of daily living? You are treating the patient's suffering and impairment, not just satisfying a textbook checklist.
Right. Which brings us to the most pervasive issue, and APRN will actually use these tools to diagnose anxiety.
Oh, yeah. Huge numbers there.
Up to 31% of adults and adolescents will experience an anxiety disorder in their lifetime. But clinically, anxiety presents in 4 distinct dimensions.
Right. It does. You have the affective dimension, like a constant sense of dread. The cognitive dimension, which is characterized by those racing, catastrophic thoughts.
Like always thinking the worst-case scenario is about to happen.
Exactly. Then there's the behavioral dimension, avoidance, or nail-biting. And finally, the somatic dimension, which includes hyperventilation, diaphoresis, sweating, and gastrointestinal distress.
And that somatic dimension requires rigorous differential diagnosis, right? Because it's driven by sympathetic autonomic hyperactivity.
Yes. The patient's fight or flight system is just in severe overdrive.
So if a patient presents with a racing heart, profuse sweating, and shortness of breath, your immediate instinct cannot just be to hand them a JD-7 and diagnose anxiety.
No, not at all. You have to be a medical detective first. You have to eliminate the physical suspects, like you must consider arrhythmias and order an ECG.
What about weight loss?
Yeah, if there is unexplained weight loss alongside the tachycardia, you need a thyroid profile to rule out hyperthyroidism. You have to rule out those medical conditions first.
I've also seen cases where older adults, maybe in their late 70s, come in with sudden, intense anxiety. And the immediate instinct is to look at their current life stressors, like maybe loss of independence or isolation. But we actually need to look at their vascular health, don't we?
We absolutely do. In older adults, vascular dementia can manifest as severe anxiety.
Wait, really? How does that work?
Well, with vascular dementia, the brain's white matter tracks. The physical neural pathways that help regulate emotional control are deteriorating. So the patient might not cognitively remember why they are terrified, but their amygdala is firing rapidly, and the frontal lobe is just too compromised to hit the brakes.
Wow, so the physical etiology is literally creating the psychiatric symptom.
Exactly.
Okay, so once you have confidently ruled out those physical causes, the thyroid issues, the drug reactions, the vascular changes, you still have to separate everyday normal human worry from generalized anxiety disorder, or GAD.
Right, and the clinical threshold there relies heavily on time. A GAD diagnosis requires extensive disabling anxiety that lasts for more than 6 months.
6 months. That's a strict cutoff.
It is. The DSM-5-TR strictly enforces this timeline to prevent clinicians from overdiagnosing the worried well. Because mild transient anxiety is a necessary adaptive human response to stress. It only crosses into a disorder when the autonomic hyperarousal becomes chronic and debilitating.
Think about what 6 months of relentless fight-or-flight activation actually does to the body, though. I mean, the adrenal system is exhausted. The neurochemistry is completely depleted.
Yeah, it takes a massive toll.
That's why anxiety rarely just stays anxiety. It basically burns the house down, leaving a profound mood collapse in its wake. There is a massive comorbidity rate here. An average of 67% of patients with a depressive disorder also have anxiety symptoms.
The physiological burnout leads directly to major depressive disorder.
Let's dive into that. Major depressive disorder, or MDD.
So MDD carries a 7% 12-month prevalence in the United States, and females experience it at a 2-fold higher rate than males, often beginning in adolescence.
And because the prevalence is so high, and the functional cost so severe, the U.S. Preventive Services Task Force mandates universal adult screening in primary care, right?
They do, yeah, with a special emphasis on pregnant and postpartum women.
Okay, so when you are in the room with the patient, you need a mental framework that won't fail you under pressure. For the student listening, you'll rely on the SIGECAPS mnemonic to thoroughly assess the dimensions of depression.
It's an essential checklist.
It really is. So you're looking at sleep disturbances, interest deficit, which we clinically term anhedonia, guilt or feelings of worthlessness, energy deficit, concentration deficit, appetite changes, psychomotor agitation or retardation, and finally, suicidal ideation.
And applying SIGECAPS requires intense clinical reasoning because, much like anxiety, depression masquerades as physical illness.
Right. A patient might just report severe fatigue or cognitive fog.
Exactly. So before diagnosing MDD, your targeted lab panel needs to look for organic causes, things like vitamin B12 or folate deficiencies.
And we're learning that a B12 deficiency actually causes demyelination of the nervous system.
It does. It slows down neurotransmission. And clinically, that demyelination looks identical to the psychomotor retardation of depression.
That is wild.
Yeah. You also have to rule out infectious diseases like HIV or early onset neurological issues like Parkinson's.
Okay, assuming the labs are clear and you've isolated a mood disorder, the differential diagnosis branches again. You have to determine if this is unipolar MDD or if you are looking at bipolar disorder.
Which requires a very careful history check for past hypomanic episodes.
Right. Or perhaps it's persistent depressive disorder dysthymia, which is a lower grade depression but lasts for years.
And within every single one of those assessments, safety is paramount. You must explicitly assess suicide risk.
What specific risk factors should they look for?
You are looking for demographic and environmental factors. So being male, living alone, severe hopelessness, intense sleep disturbances, and critical access to lethal means like firearms.
I know new clinicians sometimes dance around the topic. They're afraid that mentioning suicide will somehow plant the idea in the patient's head.
That's a common fear, but the clinical standard is unambiguous. You ask directly, are you thinking of harming yourself or committing suicide?
Just straight up.
Just straight up. Direct, unshrinking communication is actually protective. It removes the taboo and gives the patient permission to share the depth of their despair.
That makes total sense. But what if that SIGECAP profile, the severe sadness, the anhedonia, the disrupted sleep, what if it's tethered to a specific devastating event, like the sudden death of a spouse?
That changes things. Here, the clinician has to pivot their reasoning to differentiate clinical depression from the universal human experience of grief.
Grief is fascinating from a physiological standpoint because it's not merely emotional, is it?
No, acute loss disrupts biological rhythms on a cellular level. Clinical literature notes that severe grief actually impairs immune function. Specifically, it causes decreased lymphocyte proliferation.
So the body's defense mechanisms are literally weakened by the psychological pain.
Exactly. And we saw this on a macro level during the COVID-19 pandemic. It forcefully disrupted normal mourning rituals globally. The inability to gather, to hold funerals, it resulted in a massive wave of collective, complicated grief.
So differentiating normal adaptive grief from a major depressive episode seems incredibly tricky. If a patient is crying in your office and hasn't slept, how do you clinically separate the two?
You look at the cadence of the mood and the state of their self-worth. In MDD, the mood is a pervasive, unrelenting void. There's a complete inability to anticipate pleasure, accompanied by deep feelings of worthlessness.
And in normal grief?
In normal adaptive grief, the pain comes in waves. It fluctuates. The intense sorrow might suddenly mix with a fond, positive memory or even humor.
Yeah.
And most importantly, in adaptive grief, the patient's self-esteem is usually preserved. They are mourning a loss, not their own existence.
What if it goes on for a very long time?
If that maladaptive grief intensely impairs functioning for at least a year in adults, or 6 months in children, then it crosses the diagnostic threshold into prolonged grief disorder.
Okay, let's talk about clinical management in the acute phase. A grieving patient comes into the clinic, they just lost their partner, and they are desperate because they haven't slept in 3 days. Do we prescribe them something to take the edge off?
The absolute foundation of your management plan is validating their psychological pain, not erasing it.
So no heavy sedatives.
Well, a brief, highly monitored course of a short-acting sedative for acute sleep issues is sometimes acceptable, because profound sleep deprivation is a real medical risk. But you must strongly discourage the use of chemical numbing agents like alcohol or tranquilizers.
What about antidepressants?
Antidepressants are reserved strictly for prolonged grief disorder or if there is a comorbid pre-existing major depressive disorder. You cannot and should not medicate away the necessary biological process of mourning.
But when patients don't have adequate support, or when the sheer pain of unprocessed trauma or grief becomes intolerable, they often seek out their own chemical numbing agents anyway.
They do.
And that lack of coping mechanisms brings the primary care clinic face-to-face with substance use disorders.
Yes. And to effectively treat a substance use disorder, or SUD, you have to fundamentally conceptualize addiction as a chronic brain disease, not a moral failing.
The neuroscience behind it is wild.
Yeah.
Substances of misuse physically hijack the brain's reward circuitry.
They completely rewire it.
Right. Normally, engaging in a positive survival behavior releases a moderate amount of dopamine into the nucleus accumbens. But illicit drugs, or misused prescription opioids, provide a neurochemical shortcut. They flood the nucleus accumbens with up to 10 times more dopamine than natural rewards and at a much higher velocity.
And because the brain is an adaptive organ, it cannot survive that constant massive surge of neurotransmitters. It defends itself by downregulating or blunting its own dopamine receptors.
Which is the exact physiological mechanism behind clinical tolerance.
Exactly.
It's such a devastating cycle. Over time, the actual liking or euphoric enjoyment of the drug decreases because the receptors are so blunted. But the neurochemical wanting, The intense physical craving driven by the survival circuitry completely dominates the brain.
The patient is no longer using to get high. They are using to prevent the agonizing physical and psychological withdrawal.
Understanding that mechanism really clarifies how we distinguish recreational intoxication from a true substance use disorder.
It does. The clinical hallmark of SUD is severe functional impairment. The patient continues to compulsively seek and use the substance despite catastrophic negative consequences to their employment, their physical health, and their interpersonal relationships.
Historically, there was a heavy reliance on abstinence-only approaches, pure willpower models, which we now know fail to address the downregulated neurobiology.
So what is the current standard of care?
The definitive evidence-based management plan revolves around medication-assisted treatment, or MAT. The Substance Abuse and Mental Health Services Administration, SIGECAPS, strongly dictates that MAT is the gold standard. What does that entail exactly?
It combines FDA-approved medications like buprenorphine or methadone, which physically stabilize those hijacked brain receptors to stop withdrawal and cravings, with rigorous holistic behavioral therapy. It is the most effective intervention we have for opioid, alcohol, and tobacco use disorders.
The reality of severe substance use is that it rarely exists in a vacuum. It often creates highly volatile, chaotic home environments, which can mask other hidden traumas.
It's all interconnected.
So a primary care provider treating a patient for chronic pain, anxiety, or SUD must always maintain hypervigilance for the presence of intimate partner violence, or IPV.
The epidemiology of IPV is incredibly sobering. 1 in 4 females and 1 in 10 males will experience it in their lifetime. And due to massive underreporting, those numbers are almost certainly an underrepresentation.
And the fundamental aim of this violence is always control by one partner over the other. I imagine spotting intimate partner violence is somewhat obvious in a textbook sense. Visible bruises, a patient actively crying. But I'm guessing in a quick 15-minute primary care visit, it's rarely that straightforward.
It is almost never that straightforward. The physical markers are often completely hidden. What you are actually looking for are the physiological manifestations of chronic fear.
Like what?
The red flags include sudden exacerbations of chronic illnesses like asthma or diabetes, severe sleep disturbances, or chronic pain syndromes without a clear structural etiology. The stress load literally manifests physically.
And behaviorally.
Behaviorally, you watch for a patient who gives evasive, contradictory answers, or a partner who is overly attentive, who answers questions on the patient's behalf, and this is a big one, refuses to leave the exam room.
Which brings up the absolute, non-negotiable golden rule of IPV assessment. You must interview the patient alone, no exception.
Right.
But if you have a highly controlling partner who insists on staying, you can't exactly instigate a confrontation right there in the clinic. You have to strategize.
Exactly. You have to be smart about it.
Like you order a routine urine test or a seemingly urgent diagnostic X-ray, something that naturally requires the patient to go to a secure, private clinical area where the partner cannot follow.
Yes. And once you secure that privacy, your assessment relies on a trauma-informed care approach. The clinical standard utilizes Kimberg's 4 C's: calm, contain, care, and cope.
How do you start the conversation without scaring them?
You want to normalize the screening process to reduce shame, saying something like, because violence is so common in many people's lives, I ask all of my patients these questions about their safety. You use validated screening tools like KITS, which assesses if a partner hurts, insults, threatens, or screams at them, or the WASP tool.
I've heard you should be very careful with the words you use, too.
Absolutely. You must strictly avoid using stigmatizing loaded words like domestic violence or abuse during the questioning.
Because language like that can feel intensely intrusive. It forces a label on the patient they might not be ready to accept, which instantly shuts the conversation down.
It does.
If the patient does disclose violence, your scope of practice isn't to play marriage counselor or force them to leave immediately, right?
No, not at all. You prioritize safety planning. You comply with local mandated reporting laws, especially if children or elders are in the home, and you act as the bridge, connecting the patient with discrete community resources, emergency housing, and specialized mental health referrals.
Your role is basically to plant the seed of safety and provide the exit strategy when they are ready to use it.
Exactly. You are the safe harbor.
We have covered incredible ground today in this deep dive. From navigating the DSM-5 TR to unpacking the neurobiology of addiction and the hidden clinical markers of trauma. How should a student clinician integrate all of this?
I really want you to view this through the circle of caring model. An individual's mental health is inextricably tied to larger social structures, systemic inequalities, and the cumulative traumas they navigate daily.
It's the whole ecosystem.
Right. You cannot treat a patient's depression or substance use in a vacuum without acknowledging the societal, climate, unemployment, isolation, marginalization that breeds these vulnerabilities. True healing requires seeing the intersectionality of their entire lived experience.
As we wrap up this deep dive, I want you to consider this forward-looking thought experiment. We just spent all this time talking about diagnosing patients based on the subjective symptom checklists of the DSM-5-TR.
Yeah.
Right? But with rapid advancements in clinical biomarkers, like tracking chronic cortisol spikes through smartwatches, or mapping microtremors in vocal patterns using AI to detect depressive relapse, how long will it be before that murky psychiatric diagnosis becomes exactly like that broken bone on an X-ray?
That's a fascinating question.
Will artificial intelligence and biometric data make our current screening tools obsolete? Or will that hyper-technical precision make the deeply human, empathetic element of an APRN's job that much more critical?
I'd lean toward the latter, but it's definitely something to keep in mind as the landscape evolves.
Absolutely. Well, to our listeners, you have the tools, you understand the pathophysiology, and now it is about applying that knowledge in the clinic. Thank you for your hard work, and a warm thank you from the Last Minute Lecture team.
Keep learning, keep caring, and we will catch you on the next deep dive.